Well, welcome everyone. My name is Aisha Akhtar, and I am the Vice President of Health Equity at the Epilepsy Foundation of Greater Chicago. I am here with a ton of people who are behind me, supporting me. But I first want to thank Stephanie McCormick in the back. You were about to take a photo. I could not have done this without her. What I've realized is that you cannot put us on a phone call together because we will just talk for hours about, well, we should do this or we should have that. Or I think your latest idea was we should have drink orders while everyone's sitting in the room so that I mean, we just wanted to think of everything to make it a really enjoyable experience for all of you. I also wanted to thank the Epilepsy Foundation of America, to this great space Matter. Make sure you check out the OSF simulation room. That's pretty amazing. Also to Neurelis and UCB, thank you for all of you to supporting us in your health equity efforts. So I just wanted to set the stage a little bit. A couple of years ago, this idea of creating my own roundtable was something that I thought was, I don't know, a pipe dream. I thought, who's going to come to my roundtable? And here you are at the roundtable, and this is amazing. So thank you. Well, the great thing is, I don't have to do any of the talking. So, I am going to share the stage with everybody else. So that's really exciting. But it is my hope that every one of you walks away today with a new contact, a new nugget of information, or a new perspective on something that we can all do collectively to improve the lives of our patients and help them in their journey. So just a couple of housekeeping things. Maybe you already use the restrooms, but they're out on the other side of the elevator, to the left and to the right. I hope you all redeemed at least one of your drink tokens, and hopefully you voted, so hopefully that'll be something fun that we can track throughout. So we'll have more food later, so just hang tight. And we also have a very special takeaway for everyone. It's a beautiful cupcake from Sprinkles with the Lurie logo on it, so make sure you get yours. Yes, so it's very cool. So make sure, so if you have to leave early, that's fine, just make sure you get one. Yeah, okay, so that's all the housekeeping stuff. We are also raffling off a book. I'll talk about that in a second. But I want to now tell you a little bit about the flow of the evening. So your moderator tonight, again, it's not me. I don't have to speak, but I found another person with the same name, and her name is Aisha Jaco. She's the executive director at Westside United, so she will be our moderator for tonight. And when I think of Chicago Health Equity, I think of her. I think she's amazing, yes. What she does in her community is amazing, and she's really putting the west side of Chicago kind of back on the map, and especially when it comes to the death gap, the life expectancy gap between the west side of Chicago and Streeterville. Does anyone know what it is? Take a guess. How many years? 14 years. 14 years, yes. And so to that effect, there is a great book called The Death Gap, written by Dr. David Ansell. He could not be here tonight. He remembered late. He had to go pick up his wife from the airport. But he's here in his book, and so we are raffling off 5 copies, so that's why you all have a raffle ticket. So we're really excited about that. And I just want to end with just, having you all look around the room. I definitely see way more women than men, so that's amazing. But it's a really diverse room, and hopefully you'll meet someone that you've never met before. And so I just want everyone to have a good time and enjoy and networking. It's a very casual experience. And so with that, I'm going to turn it over to Aisha to kick us off. Thank you.
Thank you, Aisha. I don't get to say my own name often to somebody else, but good evening. As mentioned, my name is Aisha Jaco, and I am proudly serving as the executive director of Westside United. We are a health equity collaborative born on the west side of Chicago. It was an idea coming out of Rush University Medical Center's Community Health Needs Assessment in 2017. They illustrated the death gap that was mentioned, which at the time was 16 years on the train lines coming from the Loop into the west side. And what we found was that if you lived in the Loop, it was more likely for you to live to 85. If you lived in communities like East Garfield Park, that life expectancy dropped significantly by 16 years. So the idea was to set out answering the question, what if? What if Rush, along with Lurie Children's, who is a founding institution, Cook County Health, Ascension Health, UI Health, Sinai Chicago came together to think about their collective impact? Because if combined, they'd be the #1 employer in the state of Illinois. They have massive spend capability, about $4 billion a year across the systems. They have about 7,000 live births, and the list goes on and on. So the idea was to set a table for them to break down their competitive silos and to think about the framing of an initiative that would name and claim structural racism and historical disinvestment as key pillars, but also the social drivers of health as potential solutions. So the idea was to look at hiring practices and set targets around hiring locally from local zip codes in the West Side. And we say the West Side is everything as far south as Little Village or South Lawndale, as far northwest as Belmont Cragen, as far northeast as Humboldt Park, and as far west as Austin. So we cover an area that's about 550,000 people. And so in that spirit of coming together to think about the gap, it was not just by addressing care, access to care, but also looking at economic vitality. So again, going back to hiring, going back to thinking about how to support businesses within those zip codes who had not seen sizable investment when we think about places like Garfield Park since the riots in 1968 when Dr. King was assassinated. So there was this compilation of ideas and most importantly, the engagement of community along with healthcare to come up with a model which is now considered a national model in the health equity spectrum. And so when we come here today, I'm reminded of some of the early actions of that work where champions like Esperanza Health were part of a co-location of mental and behavioral health RFP, where they got funding to co-locate a social worker in Hammond Elementary School in Little Village, because the school didn't have a social worker, to provide wraparound supports for students. Or I'm reminded of work that we did in Little Village with Enlace to expand a community health worker model, where Enlace pledged to enroll 100, maybe about 1,500 residents into care. So the spectrum and footprint of this work is massive, and I'm proud to be leading it along with our healthcare partners, but more importantly with our community partners and with leaders like you. So as we get into tonight's discussion, we're gonna highlight different approaches to access to care, and I'm excited to be part of this first series in this kickoff around access to care. And so in talking through the voices of our key partners from Esperanza, Lurie Children's, and our Asian Health Coalition, we want to share some of the best practices, share their journeys, but then also have a dialogue with those of you in the room and outside of the room about impact. So you'll hear more from me later, and Aisha will have to make sure we're responding to the right Aisha call. But what I'd like to do is bring up our first presenter, and that's going to be Dr. Saavedra from Esperanza Health, and then we'll continue the flow of the evening hearing from all of our presenters and end out with Q&A. Thank you.
Sitting here by myself? I got this. All right.
Cozy.
Is it working? Yep. Okay.
I didn't realize I was going to be Oprah. So, I will sit.
Thanks for not making me sit by myself over here. Thank you for the introduction. So I'm Dr. Jasmine Saavedra. I'm a pediatrician at Esperanza Health Center. I went old school. I did not do PowerPoint slides. It was a last-minute decision not to do it, but I do have notes. So for those of you who may not know, Esperanza Health Center is a federally qualified healthcare center on the southwest side of Chicago. We've grown fairly quickly the last 3 years, so we are now up to a total of 8 sites. We offer multidisciplinary care from pediatric care, adult care. We have behavioral health, psych, most recently infectious diseases, women's health, and endocrinology. So we have a pretty widespread of specialties. About 95% of our pediatric population is covered by Medicaid, and then I would say for the adult population, there's a large majority who are covered by Medicare, and then there's a vast majority that's uninsured. About 90% of our patients are just Spanish speaking, but our pediatric patients do, for the most part, speak both languages. We service about 20,000 kids, which accounts for about 65,000 visits a year. This was last year's data. And then most recently, we've been having an influx of new pediatric patients that are mostly newly arrived migrants. So we have been trying to close the gap, make sure that they are having access to specialty clinics, making sure that they're establishing pediatric care. So it's been a bit of a struggle trying to make sure that they have all their needs met, but that's one of the challenges we've been facing recently. So Esperanza first created a partnership with Lurie, or Lurie found us in 2021. They had started a Connect for Children and Youth Epilepsy Quality Improvement Project. And the goal was to get our patients from community clinics to see a neurology or into a neurology clinic in a much quicker span of time versus what the typical referral was. So, and then the perk was that they also had they were starting up a Spanish-speaking clinic, which for our patients was very beneficial. So what we did was we created a Connect program referral into our EMR. We use Athena. And so any time that we had a patient with new onset epilepsy, suspected seizures, or a patient who was transitioning care to Lurie or wanted to establish care for if they were out of state or out of country, we would refer directly to the Connect program. And they usually created an appointment or made an appointment within 2 weeks. That first one was usually a telehealth appointment, but they gathered all the information they needed, any videos that they needed to see about the whatever movements maybe were abnormal. And then usually an EEG was ordered if it was necessary, and then after the EEG was completed, then they had the in-person appointment. So it was incredibly helpful to be able to get them from point A to point B within a 2-week span. We did have a point of contact, Stephanie, who was fantastic. So she was available to kind of work out the hiccups. So we let her know when we sent over referral to make sure the process was working well. She made sure that she had all the information she needed, made sure that the appointment was actually made, and then made sure that whether or not the patient actually showed up or whether or not the family didn't answer when the appointment was trying to be made. So that was incredibly helpful to make sure that the patient was actually seen for the reason of a visit. Forgot my last point. There was also a provider educational component. So there was lunch and learns, I think they were called. They were live. They were about epileptic topics. They were available to our providers to watch live, or they were recorded so that we can watch at a later date. So that was also really helpful. So our providers got expert lectures presented to them or that they can see later. I thought that the entire partnership was very successful. I can think of a few instances where I don't know what else I would have done. I had a 2-year-old patient. She had cerebral palsy, epilepsy. She had a trach, she had a G-tube, and she had just gotten here from Mexico. And she was on massive doses of medication that I did not feel comfortable refilling, and they were running out. So I reached out to Stephanie and please asked her to help me in any way she can. So they were able to coordinate care really quickly, able to get her in before her medications ran out. And even to this day, the mom is like, I don't know what else I would have done. So it was helpful for both myself and I'm sure for the patient. And then also one of the biggest things I think is when you feel like your kid might have epilepsy or they might have a seizure, it was able to ease parental stress because they were able to get that answer so quickly. They were able to see or talk to the neurologist within 2 weeks, get the EEG done if it needed to be done, and really get that confirmation or say that it was something else. So I think it was really helpful for the parents as well. There was one hiccup that kept happening. The referrals sometimes would, for some reason, get routed to the general neurology clinic. And so I would email Stephanie and I would say, you know, we sent this over. And she's like, no, it's not here. And so eventually we figured out that for some reason they were getting routed there. So they would get transitioned back and then the patients would get seen. So yeah, overall was successful.
Yeah. Cool. Okay, so with that, we're going to move on. We'll have Q&A at the end. Now I want to turn things to our Lurie team. Just want to highlight also that they have been integral in our growth as a health equity collaborative at Westside United. And so we want to hear now from Amy Tennant and Dr. Garcia Pierce about your approaches.
Sure. So I will get us started. Ours is a bit more formal, the fact that we put in slides, but I love the approach, and now I feel like I kind of wish we had done that. But as Dr. Saavedra mentioned, this really kind of kicked off back in 2019 as part of a grant with HRSA and the AAP and increasing access to care for our epilepsy patients. And what I'm going to talk about today is a little bit of kind of how we've sustained this project and what we're working on to continue to encourage this increased access to care in a timely fashion. Thank you. So I'm going to review how we're increasing access to care through our new onset seizure clinics. So I think it's first to think a little bit about what the background of this is and what our problem is. As many PCPs know, that when you want to refer a patient over to neurology or epilepsy, whether it's a concern for seizures or abnormal movements, there can be a big gap. And so looking back, we would have a range of between 1 to 3 months for a referral to clinic visit. If the PCP felt comfortable, they could start by ordering an EEG, a routine one, which is a 1-hour study. The great thing is we can typically complete this within a couple of weeks. However, there might be this large gap between the time that the EEG is actually completed and the time that the patient comes in. And then we have, again, a gap in care. So our aim was to then take this kind of original model and create a new onset seizure clinic where we would combine the appointments. So a patient would be able to have that 1-hour EEG in the morning, and then they would, a few hours later, have then an in-person or a telemedicine clinic with one of our epilepsy APPs. Of course, we assumed that this would be wonderful for families and really kind of improve the patient and family experience. So as we were thinking about this is a look at kind of the overview and what we projected before we were building this clinic. So our hope was in this project to reach over 150 patients in a year. We initially wanted to allocate 20 clinic spots per week, with up to half of these visits being telemedicine, again, increasing access to care for families who maybe were not able to come in person. And we projected that probably a large majority would follow up with our providers through telemedicine as well. We did have to get some organizational involvement as well, and so we had to advocate and did hire and onboard a new APP in order to have enough staffing. You can see our program model and what we've been doing, at least so far. So referrals come in and they are reviewed. Currently, we are reviewing these by hand, where we'll have a provider who will look at the referral and decide if this is an appropriate patient to come to this type of clinic. And so we're looking for patients who have never had an EEG before and patients who have never seen a neurology provider. As I mentioned earlier, they're going to have an EEG early in the morning, followed by a same-day visit. And at that time, we're going to review the results with the family. And then after having that conversation, we can have appropriate follow-up as needed. And even if they came here and we find that this is not the right fit, it really has helped to ensure that families then get referred to the appropriate service or provider. So here's our progress so far. So that was kind of our initial thought before we started getting this into action. So we do have a schedule. We have these coupled appointments where a particular EEG is then linked with a particular clinic visit. And we currently are running at a capacity of 3 days per week with a long-term goal of hoping to expand to 5 days per week. We have this lovely Power BI dashboard that I will show you shortly, where we're collecting our data and looking at how long it takes for a patient to come in for their EEG, looking at patient demographics, what their diagnosis actually was, follow-up, and essentially our care. And the last piece of our progress is we are working on getting this into centralized scheduling. As I mentioned before, we are going through these by hand because we are still in a little bit of a pilot phase. But in order to make this, sustainable for the system, we do need to have this kind of built into our workflow, have this part of our decision tree so patients can get in that way. So I think this is really the most interesting part of the whole presentation is a bit of data on the patients that we have so far. So we started the clinic at the very end of 2024 in November or December. I will be completely honest, I think we had a handful of patients, so not a ton. So really this got launched in January of this year. We've had 85 patients who have scheduled. As you can see, 4 were no-shows, which is a fairly low rate. Average age a little bit over 5.5 years. 1/3 of these patients were diagnosed with epilepsy. 1/4 of them were started on a daily anti-seizure medication, and over half of them were prescribed a rescue medication. I think that's just impactful to see those numbers. I do think there probably is a little bit of a skew to it, knowing that these were hand-selected patients, and if things were built into centralized scheduling, they might be a little bit different, but I think it shows the value in the clinic and what we've been able to do thus far. And then looking back at a sample for our wait time, so we looked at May of 2023 to basically this clinic in this short period of time, there is a 70% decrease in the time from referral to the time of appointment. So this is our beautiful Power BI dashboard. There's a lot that's going on the screen, so it is a little bit busy, but I will draw your eye to the corner in the bottom left, and I cannot read it from here. It might be time for glasses. So I think what is really helpful is the purplish and the orange line are looking at the time from referral to actual clinic visit and EEG, and you can just see, pretend that this is early 2023 up to June, there's a significant decrease. So when people are putting orders in, they're getting patients in quickly, they're having their EEG quickly, they're coming to clinic quickly, and so I think that is a nice visual representation, even if you can't read it. So sustainability, as I mentioned, centralized scheduling is really integral for this. But as far as efficiency, we want to make this work because it's great for our medical providers. It's wonderful to see a patient the same day and actually have some data to go through and something to work from. I think so far, Stephanie's kind of stepped in and asked parents about their experience, and we've gotten a lot of positive feedback that despite maybe being at the hospital for several hours that day, that it was a great experience and they felt like they had some answers. Sustainably, it's a project that we can grow. So if we have enough personnel, we can think about down the road of, is this something that we can expand to some of our satellite locations, which again increases access for people who are out in the community and maybe cannot get to downtown Chicago and they don't have the ability to be there for 5 hours for this. Offering different types of visits is another growth potential, and then we'll continue to collect data. Oops, I'm sorry. And lastly, but most importantly, I want to showcase our 3 APPs who have really been the ones who are running the clinic. So we have Allison Dye, Ashley McPartlin, and Kelly Nevin, and they've been integral in making this work. They've been really flexible in the fact that we have changed this several times, but I wanted to show their faces since they can't be here today. And I apologize, I probably talked too fast. There you go. Oh.
We'll just transition. Yeah. Sure. Yep. I'll do. All right, perfect. I'm Dr. Joanna Garcia Pierce. I'll be talking about the Spanish clinic that it was created this year, well, 2023.
There we go. So basically, the point and the purpose of this clinic, it was a pediatric epilepsy clinic that was created for families who identified Spanish as their preferred language. And the main goals of our clinic was to create a more culturally sensitive care, also improve the quality of care that our patients get, and also enhance their experience and satisfaction as well. And also, as we all know, with minorities, there's a history of medical trust issues, so definitely working and improving that as well. So we started this clinic actually on October of 2023, so not too long ago, but we're coming up to a year, which is very exciting. And so far, we've been meeting about twice per month on Mondays afternoons. And there we go. And as to why we created this clinic, so essentially, as you can see, with the Lurie demographics, so you can see 47% of the patients identify as Hispanic and Latino, and I think that's a good representation of our city of Chicago, right? And the other reason why we decided to do this is because studies have shown that language concordant care is better and is more positive than using interpreters and services, which they're great, and obviously not all institutions have the capability of doing this, but overall, language concordant care is better, has shown to improve patient outcomes and satisfaction as well, and has shown to reduce healthcare costs and also medical errors. So in order to do this, it took some time, but we were able to achieve it. And our goal, like I said, was to, from start to end, to make sure that everybody speaks Spanish for patients. So from the moment they make the appointment and also they check in, they speak Spanish up until they see also the provider. So from the check-in staff, administrator assistants, very important, we have a medical social worker as well, our medical assistants, registered nurse. We also have advanced nurse practitioners, and then we have 2 pediatric epileptologists, including yours truly here. So, and here's a photo, and Allie makes another appearance. She helped with 2 of these clinics. Also, there's me, and also Dr. Garcia Sosa, who I think was the one who came up with this idea. And I say that one of the first times I met you, you said one day we're going to do a Spanish clinic. So you were able to accomplish that. It just took a little bit of time. And then also we have Alicia Alonso, who's our nurse. And then also not in this picture, but very, very important is our social worker, Areli Cerda, which is very, very important. So far from the information that we have, so we have seen 56 patients ranging from 9 months old to 16 years. The majority of the patients so far have been some of the patients that me and myself, Dr. Garcia Sosa and myself, have been taking care of in the past, and we kind of transitioned them over to the clinic. But some 12 have been transferred from other providers who have found out about the clinic and felt like that patient would be best served in the Spanish epilepsy clinic. But 15 have been completely new to the hospital, and this is where I would say the majority of the patients are from that group of immigrants that have come to Chicago in the past year. And also looking at the social influencers, about 20 patients had at least one social influencer that is identified at high risk. And this is why it's very important that we have a social worker with us who's able to communicate with the patients. So these include issues with transportation, housing, etc. And then so our goals for the clinic, so I would say one thing, we definitely want to continue growing, get more patients. My hope is that we have the capability to meet more often and on different dates, because obviously Monday afternoons might not work for everybody, so that would be a goal. Also doing questionnaires and assessment. First of all, interested to see our patients feel like that by speaking the same language without any interpreter service, just directly with your provider, is that leads to better understanding of their diagnosis and how they manage their epilepsy. Also very important, like, do the seizures get better over time, right? Also the impact on the quality of life, and also what they feel like the quality of care they're receiving, and also how their comfort with communicating with a provider as well. And I would say another thing, it would be like, hopefully we inspire other clinics with that in other specialties, because so far we've gotten positive feedback from the families, and as word has gotten around, other clinic, like other departments have been like, oh, that's a great idea, we just need more people. So I feel like by showing that this works, that we continue, like the hospitals continue to hire people with different languages and keep servicing our community appropriately. Yeah, thank you.
Thank you to our presenters from Esperanza and Lurie. Now we're going to shift gears and hear from Dr. Hong Lu from the Midwest Asian Health Association.
I'm sorry, I have to stand up and close to my screen. So it's different from the other speakers. I'm going to talk about in a different community aspect about our mental health. And we don't have a clinic, and we don't have the epilepsy clinic or even a wellness in our community. So what I'm talking about really apply to this disease as well. So I'm the executive director and the founding member for Midwest Asian Health Association. We are located in South Chinatown, but we have the other sites. One is in Bridgeport, and one is in Aurora, DuPage County area. So this is a picture that we purchased a building near Chinatown. So this is a ribbon cutting open ceremony 2 years ago, less than 2 years ago. So MAHA is a 501c3 non-for-profit organization. It was founded in 2003. Our target population is low-income, medically underserved minority populations. Because we are located in South Chinatown, so most of our customers are Chinese immigrants from China. So our mission is to reduce health disparities for medically underserved low-income populations in the Midwest through providing culturally sensitive and linguistically appropriate services, which include community outreach education, screening, immunization, linkages to care, mental health services, and the research and the policy advocacy. So these are the key programs with MAHA. Health insurance navigation. So Midwest Asian Health Association is the only CMS federally funded navigator program in the past 10 years, serving Asian population. We provide enrollment services and post-enrollment services for Obamacare, Medicaid, Medicare, or kids. We also provide other benefits enrollment, including LIHEAP, SNAP, SSDI, SDI, and all those benefit enrollment. We serve thousands of customers per year from this program only. We have a mental health and substance abuse clinic. This is the only clinic licensed by the state in Chinatown. We serve most people from immigrant communities for all kinds of mental health issues. We just started to have a substance abuse gambling prevention program to help people with substance abuse and gambling addiction issues for prevention and treatment. We have an employment program to serve people with disabilities, to find the job, provide job training for people with disabilities, including mental health and other severe disability like deaf and hard of hearing. We have community health center to provide health screening, immunization, and then follow-up medical consultation. But we are not clinic. We are not FQHC clinic. It's basically some primary care screening, and then we follow up with people who have like high cholesterol, hypertension, we provide a consultation, but they have to go to seek doctor care if there is they need a medication. MAHA is the primary care center which utilized by most immigrants who work in the restaurants and work in the grocery stores and other tourist companies that they cannot afford health insurance. So they come to MAHA to get annual checkup, at least to get some very basic health screening. We have a hepatitis B and liver cancer prevention clinic. This is a volunteer clinic. It's not really licensed official clinic. We have a volunteer hepatologist come here once a month to see our patients. She prescribes medication for people who needs medication for hepatitis B virus. But if there is a further diagnostic test, then we'll refer them to UIC or Northwestern and other hospitals. This year we started a first family advocacy center in Illinois, the first Asian family advocacy center in Illinois provides family services. And then this year started February, we have a food pantry center serving about 150 to 200 per week. And then, so we serve about over 1,000 customers per month. We have to open twice a week and 8 times per month. This is the first food pantry center in Chinatown. And we are also looking forward to expand our services and our programs beyond Midwest. So I'm going to talk more about our mental health program, which is the focus of my presentation today. So the purpose of our mental health program is to provide linguistically appropriate, culturally sensitive, and financially affordable mental health services to improve our community's mental health and physical well-being. We accept Medicaid, private insurance, and a low sliding scale self-pay. But if the patients have no ability to pay, we provide free services. Our counseling services are in Mandarin, Cantonese primarily, and we have also a counselor who speaks Japanese, Malay, and then other minority languages. We have an MD psychiatrist to prescribe medication, and she's bilingual, speaks Mandarin. We provide workshops and group therapy sessions to bring people together to discuss cases. So our patient, we are still a small clinic, but our number of patients have been increased, especially during the pandemic. Most of our patients are 93% are Asians, and then 7% combination of other ethnicities. The languages speak by our patients is about 1/3 English, 1/3 Mandarin, and about 1/3 Cantonese. We have an increasing number of patients who speak Mandarin, 42%. The age group is about 1/3 under the age of 18 and about 1/3 over the age of 50. So the mental health issues, of course, apply to this disease. So this is a citation from a SAMHSA's website. 1 in 6 Chinese American young adults reported experiencing serious psychological distress. The average person waits for 10 years before seeking treatment. Mental health disorders are the leading cause of disability in the US for people ages 15 to 44, while 49.7% of Caucasians with mental illness receive treatment, but only 19.2% of Asian Americans receive any kind of mental health treatment. Among all ethnicities, Asians are the least likely to seek help from mental health disorder. I mentioned about some of the reasons, and one of the reasons the mental health rate has been increased, especially during the pandemic. There is a growing number of anti-Asian hate crimes. We don't have Illinois data, so I got this data from it's a California data that anti-Asian hate crime rose 474% in California, while other hate crimes only rose 56% from 2019 to 2021. I think those anti-Asian hate crimes increase the criminal activities and increase the mental health stress among the Asian population. So source of mental health issues, I talked about the pandemic-induced isolation and racial discrimination because the political talks about link the virus with China and China flu, Kung Fu flu, those discriminative talks and theories really impact the people's opinion about the source of the virus, and then blame Chinese immigrants for bringing the virus to the U.S. Cultural mental health stigma result in dismissal, denial, or neglect of symptoms. So people don't want to talk about it, and it's a shameful disease, and try to deny, and parents don't want to bring kids for treatment. The model minority stereotype, of course, make people in our community feel they should look good, and they try to hide their issues and the problems, and don't feel comfortable to speak up. Difficult balance in different cultures. Of course, for immigrants, I think this applies to Latino population and any other immigrants, that especially the young generation, children, they came here at home, they have Asian culture, the expectation from Asian parents, but then in school they have a peer pressure, and they are always constantly being struggling between two cultures and try to adopt different cultures, which will, of course, would add stress on those first generation and second generation to try to survive in this country. Pressure from traditional cultural values and the desire for academic success from Asian parents. I talked about the higher expectation regarding academic performance, but ignore children's emotional and mental health needs. The other reason why there's a low utilization of mental health services is there is a shortage of bilingual mental health providers and the cultural barriers in care, especially for mental health, and we are talking about epilepsy, all those areas that if there is a language communication issues, then which will make people more difficult to access to those services. Asian culture values of self-reliance and the reservation is, like I said, fear of shaming the family keeps many from seeking assistance with emotional problems. So those are the issues, the source of issues which impact Asian population from seeking help. That's why we have a very low utilization of health services due to all those barriers and issues. So strategy, how do we address those issues? And first, the strategy to reduce the stigma through innovative approaches. So if we are located in Chinatown, so if we ask people to come to mental health clinic and to talk about mental health issues, they don't come because they feel once they enter into our clinical site, clinical environment, they feel they are patients. So what we do, one of the programs we created is to invite people to come for free massage activity. And then, so massage, stress release, and then people feel comfortable. They don't feel they are mental health patients. So then we say we provide 20 to 30 minutes free massage and come here to relax. So they come. And after the 20 to 30 minutes massage, then we will invite them individually to another room to talk about why they are here. And then my counselor will not treat them as patients, it's just a free talk. Say, why are you here? Do you have any difficulties sleep or anything bothers you? Or how do you feel about your daily life? Things like that. Very, very casual, very relaxed conversation. And then from there, we identify patients for follow-up. So in this way, they don't feel they come here because they are patients. They come here just to get some free massage services. So that's one of the program that we have been developing to get people at least to the door, and then rather than make them feel they are patients and they don't want to come at all. So that's one of the approaches. And the other approach, of course, we have to hire bilingual mental health counselors to improve the language accessibility, and then bilingual health providers with their same cultural language, so they feel more comfortable to come. Social media, of course, we need to do a lot of awareness social media, but we try to avoid mental health, because once you translate mental health into Chinese language and other languages, it's very scary, because then people link the mental health as a crazy, and the people really crazy on dancing on the street and talk crazy. So they think about mental health in that area. So each time when we do social media and when we want to recruit people to come to workshop, we don't say mental health, we say something else, like parenting or how to communicate with your kids, use other languages to promote the workshop and the event, to invite people to come. They don't feel they have something problem, that they come because of the problem. And we also provide one-on-one training for the gatekeepers, the frontline staff, to help to identify people who may have problems and then refer them to other services. Parenting skills among Asian parents it's very, very important, because we know that a lot of issues of mental health among youth are caused by the parenting skills. So we organize the parenting skill training and workshops to help them to improve their parenting style and the positive disciplinary principle. So this is the site from one of the participants. She said, I learned to listen to my child first and to communicate with my child more, stop yelling to my kids, and then become more emotionally mature. So they started to learn, especially, Chinese parents are very critical. It's always negative first, very less encouraging in our culture. So now through those parenting skill classes, they learn about how to be positive and how to be more encouraging to reduce the stress on their children, so to reduce the mental health stress on their children. So all this, we try to learn and how to deal with our patients in our culture, and using the linguistically and culturally competent way to treat our population and encourage them to get more help. So that's all my presentation.
Thank you. Thank you, Dr. Liu. And let's give one more round for the entire panel of presenters. Thank you so much. Are we going to jump into Q&A? I see that, okay. So with that, what a powerful group. When I think about our work at Westside United with Health Equity, it takes big ideas. It takes champions. It takes an ability to think about how to pilot and provide access in inaccessible spaces. Some of the things that I hear you speak to that are very important to being successful is cultural competence. So thinking about the need in your community, Dr. Liu, specifically language barriers. We think about the Spanish clinic. And I'm thinking about also just the ability to have a platform in partnership with an FQHC, a major health system, to really double down and have impact. And then from a nonprofit perspective, to step in and be a gap filler for supports. It's very important when we think about the diverse needs in the care spectrum across our diverse communities. So with that, Dr. Liu, we're going to start with you, with your amazing outline of MAHA and all the amazing services. Can you speak to your biggest challenge in setting up this model for community services, if any?
Yeah, and one of the big challenges I was talking about why there is a low utilization of all kinds of health services is the workforce shortage and then bilingual workforce for to help people to treat people with different health issues. And for example, our mental health clinic, because there is a shortage of bilingual mental health providers, and we always have to hire people graduated from schools with mental health major and a social worker, but they need a working visa. But the working visa, they have to, after 1 year of OPT, which is the working permit for 1 year, they have to go to lottery to apply to get lottery, but usually it's about 30 to 40% successful rate. So our turnover rate is very, very high because we have to use international graduates for our provided culturally, linguistically appropriate services. So shortage of bilingual mental health counselor is a huge challenge for our population, especially mental health, because you have to use the language to provide counseling. Otherwise, using translators, it doesn't work well. It's not efficient. And the other shortage, of course, the challenges is in general, we don't have a FQHC clinic in Chinatown nearby. So only a few available doctors in Chinatown are not enough to help even people to accept Medicaid patients. So they try to do a lot of self-remedy, folk medicine first, and then before they really go to see doctor. And usually when they go to see doctor, it's already at the acute situation because of the access issue. So the prevention, of course, is another issue. A lot of our patients, our customers, I talk about the health screening program. They don't go for prevention. They don't go to annual checkup. They do not know their hypertension or cholesterol or diabetes status. And then a lot of restaurant workers, they eat whatever available from the restaurants. They don't have their own choice of food, right? Because they work whole day and until midnight. So whatever available in the restaurant, they eat the meals and provided by the restaurant. So it's not healthy, and they have to work a long day. And then some of them, they have cash. And after the midnight, after 10 o'clock, then they don't have any social entertainment. So they go to gambling casino to gamble because they use their cash to gamble. Some of them get really gambling addiction issue because they don't go to mainstream entertainment places for entertainment, so they go to casino, and I got a gambling addiction issue.
Thank you. Dr. Saavedra, I think about Erie Family Health, who at Westside United, we're going to be partnering for the Sankofa Wellness Village. It is a development in Garfield Park in the Madison corridor that will co-locate Erie as the primary provider and FQHC Rush will have its Center for Well-Being there and their Community Health Worker Hub. The YMCA will provide recreation, and it'll be co-locating community-based organizations. But in the co-locating of Erie, we'll be working with Lori through an initiative, Westside Healthy Parents and Babies, that will provide wraparound supports for birthing parents in a community when we look at low birth weight or preterm births that has one of the higher rates in the region. And so when we think about the work that you're doing with an FQHC like Esperanza and your reach across the city, primarily the south and west sides, and your partnership with Lori, what can you share about your model that makes it work, you know, where it has the greatest impact? And what would you share with a budding partnership like Erie, Lori, in terms of how they can double down on their impact?
So I think having the point of contact was really crucial for us. What happens oftentimes when we make referrals is that our patients have a fear of calling a place and that the person that they're going to speak to speaks English, and so they don't call or they don't know how to navigate the system. And so oftentimes these appointments are put off for months, sometimes even years, because the families are just overwhelmed, or they feel pressure to do it, or they don't even know what the referral is for. So there's a lot of barriers, and so having that point of contact to, you know, really smooth out the process, make sure that they're seen, have a follow-up, you know, to say, you know what, your patient never showed up, or, you know, we were unable to get a hold of your patient, I think was honestly a truly crucial part of what made that partnership work. Because even though there was a smooth transition, a lot of patients still got lost even in that 2-week period. And oftentimes RMAs have to make those appointments for the patients. And sometimes hospitals won't let us because they want to make sure that the patient is available. And then it creates another barrier. Now you have to have the MA make the appointment, and now the MA has to tell the parent has to confirm that they have the appointment. So having a point of contact, I think, would be crucial. So creating some kind of really close personal relationship with someone that can help assess or gauge that process is great. And then, what would be really fantastic is to have these specialty clinics or specialty providers in the community, because often the transportation is a very big barrier. They are always asking, well, what is around here? And there isn't anything around there. I know there are satellite clinics, but oftentimes as primary care providers, we have no idea where those satellite clinics are, and so we just refer to the hospital. And so I think that would also be a goal for all the hospitals to do. But yeah, having a point of, really building those close-knit relationships and having point of contact is helpful.
Thank you. And so from Team Lori, as we think about your work with establishing the new onset clinic and then the Spanish immersion clinic, what would you say the biggest pushback was as you approached to bring those to life?
I would say not pushback, but there's always been at Lurie, and it's an ongoing issue, just clinic space. There's a lot of clinics going on, so finding the actual space, I think that was one. And I think it also took some time to finding the people. It wasn't the pushback side, but it's just I think it's just more of a reflection that there should be more minorities in healthcare in general. So it's definitely been difficult to get the people in order to serve our community properly. So I would say those were the two issues: spaces and finding the people to work.
I would agree. I don't feel like we necessarily received a lot of pushback. I think there's a lot of excitement and a lot of people who really want to get involved and make this a better experience for our patients and having better access. But anytime we start something new, it's a lot of trial and error and figuring out those processes and making sure that we're doing it appropriately. And that's why, even this clinic that I spoke about briefly, we haven't really publicized this. We don't have this out there so that the PCPs are aware that this is going on, because we're trying to improve our process and want to make sure that we have something a little bit more complete before we share it with our communities. So I think that development just takes so much time, and we just have to be patient with it.
And Dr. Garcia, could you add more about just some of the short and long-term goals of the Spanish Immersion Clinic?
So I would say like short term, it would be to look at the data that we've had so far and like do questionnaires just to make sure that we're on the right track. And it is helping. And like I said, specifically, we've gotten really nice feedback from our families so far. So it would be nice to see, particularly like that we're seeing less seizures, less hospitalizations, patients getting through the workup that a lot of bit more quicker as well. I would say long term, ideally, like I said, continue to grow, hire more people, so that way we can definitely see more patients and have more days. So because right now we're mostly just seeing them, we're having the clinic about 2 times a month on a Monday afternoon, which might not work for everybody. So be able to have different clinic days and get more people. And I would say like that so far within Lurie itself, and as we're like spreading the word about the clinic, we've heard from different departments that have thought is like, oh, we just need to create that. So if we're able to show that it works and it's leading to all these positive benefits, that maybe that will give Lurie a push to create similar clinics in different departments. So yeah.
Thanks. And one final question, as you all have alluded to workforce and the shortage and the need for there to be just a workforce that reflects the patient population. At Westside United, we do work to establish career pathways for medical assistants, community health workers, respiratory therapists, et cetera. So as you think about the people in the room, the people that are listening, what would you say we should be thinking about to support the creation of that workforce? For Dr. Liu, Team Lurie, and Dr. Saavedra, if anybody would want to add closing thoughts there.
I think it would be beneficial to have more training program, and then it's just like a career path. And even if you know a lot of people, they may not be qualified to go to those professional career classes and degrees, but at least some training programs can help them to have more knowledge. Like the epilepsy, I don't think even myself or my staff, they understand this issue. And I think a doctor was talking about why her clinic has so few Asian patients. I think because they don't even know this is a treatable disease. They don't have no knowledge about whether there is a treatment because it's a so short period of disease. They still can survive, right? So they don't know this is treatable. They don't know where is the resource, where to get treatment or resources. But if we have a training program for the community health workers and frontline staff or people in the social service organizations, and they get some basic knowledge to help to educate the people at the beginning, because those people, they don't go to professional class or workshops, but they hear from the peer educators, community health workers, and talk about it. And the more people talk about it, the more they feel comfortable, and the more they feel come out to get services.
Thank you.
I think one small step would just be to you yourself be a mentor, right? Like, I encourage all my patients, please, go to college. What can we help you with? How's school going? So I think just getting out in the community and being a person where they can see like, oh, look, it's possible. There's a way to get there. And then just being a mentor to the people who are in need or who ask, I think it's a small step. There's only so many people, but I think it's, at this point, anything helps.
I think exposure helps too. There's a program at Lurie, and I'm gonna, I cannot think. It's like career pathways. Yep. I had a student with me today. Oh. Sorry. But I was saying that I think a lot of it is about exposure. And so we do have a program at Lurie that we've had for many years where high school students will actually come in and go through different departments and shadow different types of individuals who all work in the healthcare system. And so I think that there's a lot of opportunity, a lot of career paths that they can take that they just didn't even know existed. and they have an interest in healthcare and they want to represent their community and want to make a difference, but maybe something seems so grandiose or out of reach, and then they find something that maybe they have an interest in and it's a good fit. And so I think that's something that we should continue to do. Thank you. Thank you.
Yeah, no, exactly. I was just gonna say the same thing. I think that's a wonderful program, and last week I had somebody with me, and for me, representation was very important. As I was early on in my career, so I hope that I paid it forward there. But I think other institutions having similar programs, I think it would be great. It's okay. And I think, but besides that, I think that's a great way to start. But I think overall, it's just it's been an ongoing issue for a long time, and also now with the issues with affirmative action, I think later on down the road I hope that the gap doesn't continue to widen, but I do think that Lurie making programs like this, and I hope other places are doing that to improve the exposure, so that way we increase the number of minorities and make it seem hey, I could do it, you could do it. So yeah.
Thank you. And that, that is part of access to care, making sure that there are pipelines and things in place. So thank you all for joining and sharing your perspectives and spending time today. With that, Aisha, I'll pass it back to you because I know you have different things.